Good morning to you all. I'm Professor Ellen Mendelsohn, and I come from Chicago. I've come to Athens now for quite a few years and always enjoy being here, and I'm happy once again to be able to talk to you. The areas of my interest are ultrasound, of course everything in breast, but particularly ultrasound, and Professor Bamber's lecture really is a very good complement to the clinical observations about technique and performance and how we can optimize those with examples and then avoid some of the pitfalls. So we'll look at how interpretation is tied to image quality, the technique, equipment, and transducers, just really to reiterate from the clinical perspective what you heard so very well in the last presentation. The equipment for breast ultrasound should be high-end and high resolution. You should look for a console that's user-friendly with a touch screen or whatever you like to have. For screening, there is excellent software to enable you to pre-program the annotation and save time. We'll talk more about that tomorrow, technique for screening and how it may differ from that for diagnosis. Spatial compounding you heard about, and we'll show you some more examples of how that can improve your clinical approach. And then color power and elastography are topics for separate lectures that you'll hear after the coffee break. This is just an example of one console that shows you in a redundant way how what you can accomplish you can do with a touch screen or a knob or a slider. So whatever suits you is what's provided for you. These transducers also we talked about, and here the broad bandwidth linear transducers are what you should be looking for handheld breast ultrasound. The center frequencies, and when I give you a recommendation like this, it's coming from the guidelines that have been published and are periodically updated by the American College of Radiology that has an accreditation program. So now the center frequency, and I'm not really sure what that is, but it's been there for 20 years, is 12 megahertz or higher. So I've shown you there on that list, and I hope you can see it, the frequencies that you'll encounter most commonly that are most effective for scanning the breast. For larger lesions, you may need a lower frequency transducer, but it's not that often, as you'll see. And there, I would restrict usage of those. You will compromise your own diagnostic capability. The footprints of most of these transducers are 38 to 50 millimeters, and you can see that if the footprint is a little bit wider, you'll be able to be more efficient in your scanning of a breast as you do whole breast ultrasound. Tissue penetration that you should look for is certainly to 5 centimeters. Some will give you 6 centimeters of depth, but you should look also at the default settings that the manufacturers have put on their equipment. In many cases, it's 4 or 4.5 centimeters, which may be too deep, and you lose information at the bottom of your image. So what it will be as a reminder to you is for adjusting for each patient and for the position of the patient in that scanning to what you need for maximum information. Electronic focusing and then the single sweep panoramic type of imaging I'll show you that's not suitable for screening, but very nice for looking at large breasts. So here, and looking for functionality, And comfort, ease of use. You have a transducer. I'm just showing you three different aspects of it. And here the cord emanates from the top of the transducer. You could hold it with your hand over the top or hold at the waist. Some people like that. More commonly, you'll find the cord coming from the center of the transducer. Here you'd see a 38 millimeter footprint, and this is another type. One is not better than the other. It's what suits you. And there you need to select for functionality the comfortable fit for diagnosis, for detection, and certainly for guidance of interventional procedures. So how does transducer frequency affect image? Here are some images for you to see, and if the light is too bright, you may be able to see better if we bring the lights down. Here it's 7.2 megahertz compared with 14 megahertz in the center of these things. First, look at, and as you read articles in journals, look to see if they're showing you the image parameters. There you can tell if what they're showing you is an accurate depiction of something, or whether you can judge really the image quality of what you see. In some journals, it's not really very good. So you be the judge and be critical in what you read. Here's an image at lower frequency. Yes, you can see that you've already made the diagnosis. This is a cancer. The carcinoma, you see all of the morphologic characteristics. At a higher frequency, the sharpness, the detail emerges, and you do see the features that you use for diagnosis more clearly. Here, another case, not so different, and both of them, I think, are diagnostic. So where do you think the focal zone should be? So look at the side of the image there. You'll see that here, what we're looking at is a duct containing calcifications. Yes, you can see them at the lower frequency. The lower frequency is still acceptable. For this, it's 12.5. And here, 17.5, you see much more sharply with this very broad focal range that does include this duct, and a little bit of ring down from each one of the calcifications. So the sharpness improves, and here these are work done with spatial compounding, as Professor Bamber showed you. Now, what about compression? This is it's a very old image on your left, and it's very bright and very noisy, very speckly. So what's your diagnosis here? Can you make a diagnosis? You're looking at margin. Is that a circumscribed margin? It's a messy looking margin, I'll tell you that. And then if you go to another technique, and it's the same transducer, and it's the same instrument that's being used here, with some compression, you are able to penetrate better through the tissue. You can see it a little bit better. It was a simple cyst, but here on the left, it's non-diagnostic. So watch the gain, the focal zone settings, and the resolution that you are achieving with your transducer. Another case that just shows you the difference at 7.2 versus 14 in the depiction of a simple cyst with good technique, a better transducer, and the appropriate compression. Depth of field is something else you should control. I mentioned it at the beginning. And here, an older scan. The field of view is too deep. Is the resolution of the muscle adequate? No. It's set at 5.5. Your muscle is right around 3. What does this show you? Nothing, right? You're in the chest there. And can you make out this lesion. It's just a small cyst, but here it is at a 5 millimeter mass, 7 millimeters from the skin, and you have a setting that is 5.5 centimeters deep. Inappropriate. Another case, these are orthogonal views. Note that you do have all the parameters there that you can judge the appropriateness of, and the location and the transducer angulation against the tissue. Here you see that you have excellent resolution of the muscle, but blue line, below the blue line, what information do you have? None. Okay, EZ stands for empty zone, and you don't want to see an empty zone. Okay, here it's for you a case of a patient, this is not screening, this is diagnostic, who came for pain and a palpable mass. So this was the image, and in the US, many of these studies are done initially by technologists, and then they bring the images to the breast imaging radiologist to be assessed, and for the radiologist to go back in and do real-time imaging. And what do you think of this? This is the technologist's. See anything? What's over here? So on real-time imaging, moving the transducer a little to the left, this is the area directly over the pain and the palpable finding. So what's your diagnosis? Do we need MR? We don't need MR here. And for those of you who do mammography and use it in correlation with ultrasound, these are images with the implants in place with very light compression just to stabilize. This is a lateral view or mediolateral oblique view of the left, and this is the right breast with extravasated silicone there. When you displace the implants or push them back a little bit so that you can draw out the breast tissue, you can see the breast tissue better on mammography. As you see here, all you see really is a fatty breast or a scattered fibroglandular breast with extravasated silicone. No cancer here. So how do we image large masses? And I'm going to try to move a little bit more quickly so that we make up some time. We were a little bit late starting. So imaging large masses, there are several ways to do it, and it's important for you to see the entire mass on a small field of view. The field of view for a rectangular or square image here obtained with linear transducers that are broadband are about 5 centimeters square maximally. So you may have a mass that is larger than that. Here's one. This is the typical appearance. This is a seroma or a post-surgical fluid collection in a patient who had had a lumpectomy. So here's what we can see. We don't see the posterior aspect of the mass or the lateral aspects of the mass. With a trapezoidal type of opening, sort of sector type of imaging, we do reduce the resolution and we are enabled to see all of that. And you see here the scar that goes up towards the skin, and you can recognize this as post-surgical along with the clinical history. Imaging large masses here too is a problem. This is a big fibroadenoma. You can see half of it on each one of these frames. You can splice it this way if you can match up the edges here and get an approximate length of this mass. But this is not very elegant, but it works if that's all you have. Another way, and many transducers or many systems will enable you to do this, some will not. This is a extended field of view, a panoramic sweep, and here you see multiple cysts in the area of fibroglandular tissue. And the extent that you're looking at is probably 12, these are centimeter markers up here, 12 to 15 centimeters. Here is another such case. This is an older one. Many of these examples I'm showing you, we have published in BIRADS, and I'll talk tomorrow about BIRADS, which stands for Breast Imaging Reporting and Data System, which for mammography, ultrasound, and MRI is a basic interpretation guide, as well as an outcome assessment and audit for breast imaging. And it's been in place for many years and is widely used. So here you have really extended and invasive lobular cancer. It probably extends for more than what you can see, but this extended field of view, which you can practice, and we will later on this afternoon, is very helpful in looking for extent. The best way, in my view, is to use automated ultrasound at this time, which enables you to see on a single view or in a single plane, the coronal plane, the entire breast. This interesting case this is not cancer. These are multiple abscesses that are hard to treat. So this is granulomatous mastitis. This patient was not in pain. She just had palpable masses and a lot of things. It is very difficult to treat, sometimes with steroids. Often surgery does not help, and it's recurrent and may be bilateral. Focal zone settings we will go to, and now here I wanted to point out that when you're looking for superficial lesions, with many of these systems you should use either a gel offset pad for distance between the transducer face and the skin to put in the appropriate focus the superficial lesion, or use a thick layer of gel that you can apply and just scan lightly through that. But here, the question is, what are we looking at? Is this artifact or is it a complicated cyst? In any case, it may be either one, and it probably doesn't matter for this particular lesion. But how is the gain adjusted here? It's very poor. This scan is too white. You really can't see much. And where is the focal zone? It's way down here. It has nothing to do with this lesion that we are sitting and looking at. In any case, it may or may not have been artifact, but probably was. And here, with a better adjustment, but still too deep a field selected, we can see that this is a simple cyst. What about high contrast? This is a very important thing to keep in mind. High contrast for breast doesn't belong. Black and white is not for breast imaging. It's for vascular imaging, but not for breast. So we have here a lesion. Do you want to call it anything? I can't hear you. A non-parallel cyst. What do you do with a non-parallel cyst? Can cysts be non-parallel? Okay. Also, can you evaluate on a single image in a single plane? Okay, that is key. You cannot. As far as the orientation of cysts go, most of them are parallel. But the non-parallel gives you a question. Now, what about the margin here? It's not diagnostic, is it? You want to, it looks sort of circumscribed, but that's not allowable. So in another case, this has the same diagnosis. So what do you think about that? I'm only showing you one view, and in most of the cases that we published in BIRADS, we show you orthogonal views, these small frames. It's the best we could do, but at least it gives you the option to look at margin, shape, and orientation. So here, what do you think now? Yes, this is it's not really a round, it's rounded, but the shape is really irregular because it's not round or oval, or you can't tell because you don't have another view. But the margin is key here. What are the other features? I don't know. So what would be your management of this? What would you do with this other than evaluate it fully, which is not here? In any case, the point here is that this is a high-grade tumor. This is an evasive ductal cancer, triple negative grade, histologically grade 3. Another case that's similar to higher contrast. Excuse me. Do I need a microphone? Oh, I see. We started this lecture approximately 15 minutes late, so I may go in about 10 minutes, it might be, but we have a coffee break. All right, so here we have kind of a dark image with, what, a 5 millimeter, 6 millimeter, something sitting there in the breast tissue, the fibroglandular tissue. We've got decent field of view and all that. Okay, so this is just another example of the same thing. This happens to be a high-grade tumor as well. And with just even a little bit better, and this isn't great either, a little bit better adjustment of the parameters, you see that the margin, even on this small tumor, is not circumscribed. When it's not circumscribed, it's not circumscribed, and it needs to be taken care of. Professor Bamber showed you and talked to you about dynamic range, and what we really are looking at are shades of gray, not black and white, to optimize that. Spatial compounding, again, the noise and speckle are reduced by these beams angled into tissue, which helps you in marginal definition. Anything that helps you in marginal definition gives you an edge for diagnosis. And again, a conical, columnar, this is columnar and this is conical for the conventional versus the spatial compounding. Here, even more easily seen. And remember, too, as you look at these images, your viewing conditions are important as well. If you've got bright lights on in where you're reading these images or looking at them or where you're scanning, you'll have a harder time adjusting your eyes to see these subtle changes. So make sure that you are doing the best you can for yourselves and for the patients. So here, conical and columnar. Harmonic imaging we talked about, and shadowing. Here, scanning. You're looking, now we're doing more and more screening, supplemental screening, or in some areas, primary screening using ultrasound. An older case, the question is this little thing sitting in the crotch of fat lobules a little mass? We see some shadowing, but yeah, is it at the edge or not? So how do you adjust for that? You don't want to say you don't know. You want to do your best to say you do. So change the patient's position a little bit vary the amount of compression or the probe angle to reduce artifact, and ensure even gel coverage. So don't move the transducer too much, because then you'll be in a different location. So how do you measure? You find the long axis of a mass, and just keep and then the short axis, or the orthogonal view, is measured against the long axis of the mass. So your frame of reference is the mass, not the rectangular field. Color and power we have talked about. I just wanted to show you a couple of patterns. Here we have, there are 3 cases here, how important the variation of the compression, PRF, and frequency are. And with adjustment that's proper, and you'll hear in a separate lecture more about that. Patterns can help you too, not just vascularity. Internal vascularity just tells you that you have living tissue, doesn't tell you much else. But here's penetration from the outside into a lesion, and always, of course, look at the morphology. This is a invasive ductal cancer, also high grade. So here we have penetrating. Here we have a hypervascular tangle, and this you can remark on. It's the same diagnosis. An interesting case published in BIRADS also. If you can see the microcalcifications in this breast, and then look at the corresponding B-mode ultrasound, you'll see these are all ducts, and within them, and they're abnormal in their arrangement and pattern. There's architectural distortion in and around it, and calcifications you can see within. Here is the power Doppler image, which also is very interesting in that it may delineate the area that's involved, which is a large area, as you can see here from the centimeter markers above. Rim pattern is another something that you may want to, it's not specific, and none of these is specific, but this is suggestive. And is this a cancer or is it an abscess? This is an abscess, and frequently we see the rim pattern there. Elastography, we will hear a lecture on by Dr. Vortzis. And just to summarize, we've talked about technique, using an offset for skin or intradermal lesions, optimizing grayscale, and how important that is without losing contrast resolution. And the importance of individualizing these studies, I can't emphasize enough, and a selection of the appropriate field of view. You don't want to pseudo-magnify something. It will degrade the lesion characteristics, and if you have too deep a field, you will have a reduction in information. So in conclusion, accurate interpretation relies on excellence of image quality and technique. Standardize for your department or your practice the images that are to be included for both diagnostic and screening studies. So you want the same thing applied for these patients with individualization as needed for the pathology. How to position a patient to see various areas of the breast is also important, and we can practice that at the workshop. And then remember the potential pitfalls as you evaluate images, as you read articles, and as you scan, and as you evaluate. And I thank you very much for your attention.